Thank you all so much for having me here today. So I've been working on infection prevention in long-term care and nursing homes for several years now. So I'm going to be talking to you about the overuse of antibiotics in the elderly, something I'm very passionate about, and an initiative that we have created in order to try and limit this. So when I was being trained in medical school, they often told us to, in general, push antibiotics early and often if there was any concern for infection. And I think that we are now realizing some of the negative consequences of this. In the past several years, we've seen a dramatic rise in these multi-drug resistant organisms, or superbugs, these bacteria that we sometimes don't have any antibiotic options for. We've also seen a large rise in the Clostridium difficile infection. So this is a diarrheal illness that develops in response to antibiotic exposure, and it carries significantly high mortality and morbidity rates, particularly in older adults. So in response to these changes, the government formed the National Strategy for Combating Antibiotic-Resistant Bacteria in September of 2014. And the strategy basically outlines plans to bolster our antibiotic stewardship programs as well as improve our infection prevention. And what we learned from some of this is that antibiotics are vast, and what I've learned, honestly, from being in these nursing homes, is that antibiotics are vastly overprescribed to older adults. These are their pills falling down. So research shows that up to 75% of antibiotic prescriptions that are given in the nursing home are considered unnecessary or are not concordant with guidelines. Up to 50% of nursing home residents are receiving at least one course of antibiotics in a 3-month period living in a nursing home. The problem here is that these older adults are particularly at risk for experiencing a lot of the side effects that we see with antibiotics. So things like normal GI upset, nausea, vomiting, kidney injury is very severe in older adults. Clostridium difficile infection, which I mentioned earlier, a major problem in nursing homes, liver injury, or rash. And there's more. Beyond these immediate side effects, we're also seeing prolonged side effects that can last for weeks to months to even years. We've shown that antibiotics exposure can lead to resistance and actually alter your microbiome for a prolonged period of time. So consider here a new nursing home resident that hasn't had a lot of healthcare exposure. They have a relatively healthy microbiome, hopefully, with little resistance in the bacteria that make up their normal GI flora. They get a round of antibiotics, and while that round of antibiotics does kill the bacteria that may be causing the illness, it's also going to kill a lot of their good, healthy bacteria that's protecting their body from infection. And with that, you leave space for the resistant bacteria, the ones that are able to evade that antibiotic, to grow, take over, and then transmit their resistance. And we've seen that these effects can actually be long-lasting. We don't even know how, there's differing data on how long residents stay colonized with these resistant gram-negative rods, but it is for a very long time. The issue is this is a major public health issue. We are rapidly losing antibiotic options. We cannot develop antibiotics at the rate that we are developing resistance to them. You all may have been in a situation where you have, where a loved one has been prescribed ciprofloxacin, which is a fluoroquinolone up here for a suspected urinary tract infection. And our fluoroquinolone rates of resistance in some parts of Maryland are over 30%. This is an antibiotic that we use all the time, and we're losing it as an option. So in response to this, we've had a major push to bolster our antibiotic stewardship. So what do we mean by antibiotic stewardship? This is typically run by an ID-trained physician or an infectious disease-trained pharmacist, and the goal is to facilitate appropriate use of antibiotics. So thinking about using the right drug, meaning the most narrow spectrum drug for the likely infection, at the right dose for the right reasons for the correct duration, and not obviously treating your colds and flu with antibiotic if you don't need to. And this is how I think that the antibiotic stewards were seen in the past, sort of as these villains coming in, slashing physicians' rights to give antibiotics to their patients that desperately needed them. And this is how I think we saw ourselves, as heroes coming in, protecting global health and antibiotics for the future. But I think we need to start reframing this. I think we need to start working collaboratively to protect our patients and use antibiotics in a judicious fashion. So I'm going to go into this a little bit. The way that I think antibiotic stewardship has been looked at in the past is as more of a technical problem. And what I mean by that, say your computer shuts down, you call a tech support, ask them to come fix it. You have water leaking in your house, you call a plumber, ask them to come fix it, which is kind of how we've done this, right? Like the steward comes in and says, you can't use that. They don't really delve into why or what's going on behind all that. So unfortunately, inappropriate antibiotic prescribing is really just not an easy fix like that. Think about all the different underlying social motivations and issues that go into a physician making the decision to prescribe an antibiotic, especially in the long-term care or nursing home setting. So you have older adults with vague clinical symptoms. You can't tell if it's truly an infection or if they're just dehydrated. Maybe you have poor communication between the nurse and the prescriber. Often the prescribers are off-site, so you can't really get a good picture of the story. Family pressure, very, very common in long-term care. Fear of litigation, belief they may be preventing sepsis, limited diagnostic resources, the list really goes on and on. So you understand here that there's so many other things going into this, it's not something we can approach technically. So the thought is to start looking at this as more of an adaptive problem, meaning this will require learning on both the side of the antibiotic steward as well as the prescriber in order to create a culture change the way we think about antibiotic prescribing. We need to reframe the landscape of antibiotic stewardship, make this a patient safety issue, put this at the forefront, and approach this from an adaptive standpoint. So the idea of patient safety in healthcare actually really only came about relatively recently, and it was sparked by this book by Linda Cohn, To Err is Human. And the book showed that 98,000 deaths were caused annually by medical error alone, which really sparked the patient safety initiatives from a government standpoint. So the Department of Defense came out with a patient safety initiative, followed by the Joint Commission, followed by the Team STEPS program, which was a collaboration patient safety between Department of Defense and AHRQ. And most recently, in 2011, the CUSP program, or the Comprehensive Unit-Based Safety Program, was created as a collaboration between AHRQ and Johns Hopkins Armstrong Institute, which looked at engaging all levels of the healthcare staff, improving their teamwork and communication in order to help identify medical errors and improve patient safety. So, the goal was to reduce healthcare-associated infections. So we used a lot of these ideas from the CUSP program in order to develop our antibiotic stewardship initiative, which basically uses some of these ideas. So we're merging patient safety methodology with these adaptive and technical aspects of the approach to antibiotic stewardship in order to change the way prescribers throughout the healthcare field look at antibiotics. So the National AHRQ Safety Program for Improving Antibiotic Use spans the healthcare system. So it actually rolled out to 500 acute care sites starting in December of 2017. We just finished up a pilot in 6 sites, 6 long-term care sites in December, or just finished it up in March, and we'll be rolling out to national sites all over the country in December, and this will be followed by ambulatory care. So the intervention is multimodal, multidisciplinary, and each of the interventions are created for that specific site. So we have specific cases for long-term care. We basically walk the long-term care facilities into choosing who to use for their stewardship program, showing them how to track their antibiotic usage, teaching them how to talk to families and residents about antibiotics, showing them how to track their usage, all things that have not been done in long-term care really to date. So the Centers for Medicare and Medicaid have recently posted these mandates that all long-term care facilities will require antibiotic stewardship programs by November of 2018. So many of these facilities are really scrambling for an answer to this. I won't go into everything that we do with the program, but this is an example of some of the tools we've created. So this is I don't know if this works. This is a commitment poster we created to help educate residents and family members about the risks of antibiotics. This is a 4 moments graphic, basically to walk the prescriber through how they're thinking about the antibiotic prescribing process, making sure that they're considering narrowing at all levels. And so I know we don't have a lot of time, so I won't go into all the outcomes and everything we're going to do, but the goal is to basically improve the safety culture throughout the facility, reduce these side effects we've seen from so much antibiotic overuse, including Clostridium difficile infection as well as the multi-drug resistant organism rates, improve antibiotic decision making and the safety culture in these facilities, and finally to help them improve compliance with these new government mandates. I'd be happy to talk to anyone further about this afterwards, so thank you very much for having me.
I have a quick question. I do a lot of data analytics for third-party payers, and something that we're always challenged with is hospital system algorithms. Around, okay, you were in the hospital in the last 3 months, 2 months, 1.5, whatever it is for that particular system, so you go on a fluoroquinolone. So there's a lot of algorithmic care deciding patient-level outcomes. I would like to know your thoughts on that.
Yeah, so I mean, this is a challenge that we have been navigating pretty much nonstop. I guess in terms of, are you asking like in terms of what antibiotics they've been exposed to or the outcomes from fluoroquinolone use?
No, I'm just meaning that, we all talk about we need to do something to help individual patients.
Yeah.
But we aggregate everything so high up and create algorithms that are driving the problem at like a two-headed snake.
Yeah.
Where do you intervene?
Yeah, so I agree with that. I mean, and that's why I'm very excited about this program, because I think the goal is not to just be looking at the numbers and telling them you can only use fluoroquinolones 50% of the time. It's that, you need to have these rates for your readmission, and more to just get them thinking about why we're making these decisions and helping them to understand the downstream complications of those decisions.
Thanks very much, Mark.
Thank you.